It's time for another warm-up review. Let's get going. What is the initial treatment for ventricular tachycardia when there is no pulse? So we treat pulseless VTach, just like ventricular fibrillation, with CPR until you can immediately get them defibrillated. Next, what is the function of catalase? Well, it's going to degrade hydrogen peroxide into water and oxygen. Next, which portions of the hypothalamus are inhibited by leptin, which are stimulated? So leptin inhibits the lateral area or the lateral nucleus, and it stimulates the ventromedial nucleus. All right, that's it for the warm-up. Let's get to that lecture.
In this video, we're going to talk about the basal ganglia, which is a region of the brain near the thalamus that's vital to regulating movement. The basal ganglia receive a variety of inputs, and then they coordinate all these signals by either facilitating movement or inhibiting movement. So let's talk about how the basal ganglia regulate movement first, and then we'll look at some movement disorders like Parkinson's disease and Huntington's disease. So the cortex decides what part of the body you're going to move, but the basal ganglia regulate the amount of movement. There are 6 basic parts that make up the basal ganglia. There's the caudate nucleus and the putamen, and they function together as a unit called the neostriatum. There's the globus pallidus externa and the globus pallidus interna. There's the subthalamic nucleus, and the last part of the basal ganglia is the substantia nigra, which is Latin for black substance, because when you cut open a brain, the substantia nigra is dark and pigmented. The substantia nigra can be subdivided into the substantia nigra pars compacta and the substantia nigra pars reticularis. We'll talk more about those a little bit later. Now, all these parts of the basal ganglia are communicating with one another and regulating movement by inhibiting and stimulating each other. They use glutamate as an excitatory neurotransmitter, and they use GABA as an inhibitory neurotransmitter. They also use dopamine, which can be either excitatory or inhibitory, depending on what receptors it activates. So take a look at number 4 in the study guide. Now, I don't want you to try to memorize this convoluted pathway, but it's helpful to go through it. And you might try color-coding the connections red or green in your study guide. The thalamus sends an excitatory signal to the cortex, which facilitates movement. The globus pallidus interna sends an inhibitory signal to the thalamus, which inhibits the thalamus. So the globus pallidus interna inhibits movement. The neostriatum modulates the globus pallidus interna in 2 ways. There's the direct pathway, in which neurons from the striatum directly synapse on the globus pallidus interna. So this direct pathway inhibits the internal globus pallidus, so there's less inhibition of the thalamus. In other words, the direct pathway is inhibiting an inhibitor, making the output from the thalamus stronger, and you get facilitation of movement. So the direct pathway facilitates movement. We'll come back and look at the indirect pathway in a moment, but for now, let's look at the substantia nigra. Remember how I said the substantia nigra was divided into 2 parts? Well, the substantia nigra pars compacta sends signals to the neostriatum. These neurons produce dopamine, which acts on the D1 receptors in the direct pathway. Now, that's an excitatory signal, so the substantia nigra stimulates the direct pathway and it facilitates movement. Now we're ready to look at the indirect pathway from the neostriatum to the globus pallidus interna. So the indirect pathway is indirect. It goes through 2 other sites before it gets there. It goes through the globus pallidus externa and the subthalamic nucleus. Let's go through each of these, working backward from the internal globus pallidus. The thalamus is still sending its excitatory signal to the cortex, and the globus pallidus interna is sending its inhibitory signal to the thalamus, which again inhibits the thalamus. So remember, the globus pallidus interna inhibits movement. But the subthalamic nucleus sends an excitatory signal to the globus pallidus interna, which means the subthalamic nucleus is further inhibiting movement. Meanwhile, the globus pallidus externa sends an inhibitory signal to the subthalamic nucleus. So this is disinhibitory overall, because it makes the signal coming from the subthalamic nucleus weaker, which means the signal coming from the internal globus pallidus weaker, so that the excitatory signal coming from the thalamus is stronger, and that facilitates movement. Then, going one more step backward up this indirect pathway, the neostriatum sends an inhibitory signal to the globus pallidus externa. So this is disinhibitory. It's like a double negative. If you inhibit the inhibitor of an inhibitor, the overall result is inhibition. So the neostriatum inhibits the globus pallidus externa, which increases the excitatory signal from the subthalamic nucleus and increases the inhibitory signal from the globus pallidus interna. So this inhibits the signal from the thalamus. So while the direct pathway facilitates movement, the indirect pathway inhibits movement. But now look at the substantia nigra one more time. The substantia nigra pars compacta sends signals to the neostriatum using dopamine again. Now remember, in the direct pathway, dopamine was acting on excitatory D1 receptors, so dopamine was facilitating movement. Well, in the indirect pathway, dopamine is acting on inhibitory D2 receptors. The transmitter's the same, but the receptor's different and the results are different. Dopamine stimulates the direct pathway, but it inhibits the indirect pathway. And since the indirect pathway inhibits movement, dopamine, which inhibits the indirect pathway, facilitates movement. So here's the bottom line, the take-home message. Whether we're looking at the direct pathway or the indirect pathway, dopaminergic signals from the substantia nigra to the neostriatum have the same result, more movement. So there are 2 points that I think are high yield from all this convoluted pathway. Number 1, lesions of the substantia nigra pars compacta cause hypokinesis, less movement. For example, Parkinson's disease is caused by damage to the substantia nigra. So when you knock out the dopamine-producing neurons of the substantia nigra that should normally facilitate movement, you get inhibition of movement. You get hypokinesis. And number 2, lesions of the subthalamic nucleus cause hemibolismus, which is a disorder of too much movement. So the subthalamic nucleus inhibits movement. So if you lesion that nucleus with a lacunar stroke, for instance, and you remove that inhibition, you're going to have too much movement. We'll see that shortly. Make sure you're familiar with both of these points. Now let's talk specifically about Parkinson's disease. Parkinson's disease is a neurodegenerative disorder where there are intracellular inclusions called Lewy bodies inside the cells of the substantia nigra pars compacta. And these Lewy bodies interfere with normal neuronal functioning. So you lose the dopaminergic neurons, and therefore you lose the ability to make dopamine. Normally, these dopaminergic neurons are pigmented with melanin because dopa is a precursor to melanin. As a result, when you lose those dopaminergic neurons, you stop making dopamine. You also stop making melanin. So the substantia nigra is no longer nigra. You have depigmentation of the substantia nigra. Now, clinically, Parkinson's disease causes a paucity of movement, a lack of movement, hypokinesia, bradykinesia, or even akinesia. If these patients can't initiate movement, they can't make small adjustments to maintain their balance, they can have postural instability. And this combination of bradykinesia and postural instability can lead to something called a festinating gait, where these patients have trouble initiating walking. And once they actually do initiate walking, once they start going, they have trouble stopping themselves, and they're kind of falling forward. And they're kind of shuffling their feet to keep upright, to keep themselves from falling forward. And we call that festination, or a festinating gait. These patients also have a resting tremor called a pill rolling tremor, kind of like they're rolling a pill in their hand. They can have cogwheel rigidity, where you try to passively extend the patient's arm and they sort of have these reflexive contractions that sort of catch like you're ratcheting through a cogwheel. Another classic finding in Parkinson's disease is mask-like facies. They have hypokinesia of their facial muscles, and their faces tend to be sort of frozen and expressionless. I also want to mention one unusual cause of Parkinsonian features, which is a chemical called MPP. So say you were really struggling to make ends meet with your student loans. So you decided to go all Jesse Pinkman and start cooking synthetic meperidine or Demerol to sell on the street. In the process of making that synthetic meperidine, you might be exposed to a chemical called MPTP, or methylphenyl tetrahydropyridine. So your body metabolizes that MPTP with monoamine oxidase to make something called MPP, which is methylphenylpyridinium. And that MPP basically destroys the dopaminergic cells in the substantia nigra by inhibiting the electron transport chain at complex 1. And that destruction of the dopaminergic cells in the substantia nigra can cause Parkinsonian features. Now let's talk about the ways that we can treat Parkinsonism. The patient has lost dopaminergic neurons in the substantia nigra, so one treatment strategy is to increase dopamine production. Now you can't just give dopamine because it doesn't cross the blood-brain barrier. So instead of giving dopamine, we give levodopa or L-dopa, which is a precursor of dopamine that does cross the blood-brain barrier. So when there's more levodopa around, the enzyme dopa decarboxylase can convert it to dopamine. So levodopa is the first-line drug for treating Parkinson's disease. The problem with levodopa is that it doesn't all make it into the CNS. Some of it gets converted to dopamine out in the periphery. That can lead to hypertension and arrhythmias. But probably a bigger side effect is the risk of hallucinations and delusions and psychosis. And tolerance also tends to be a problem. You can have something called wearing off phenomenon, where the hypokinesia comes back in between doses. So, levodopa is almost always given with a drug called carbidopa, which inhibits the enzyme dopa decarboxylase in the periphery. So this allows less levodopa to be converted to dopamine in the periphery, and more of it makes it into the CNS. And this reduces the side effects and increases the bioavailability of levodopa. Now, what about some other drugs to treat Parkinson's disease? Well, there's a mnemonic balsa, like balsa wood. It's been around forever, but my big problem with balsa as a mnemonic is it doesn't really list the drugs in their order of preferred use, and it leaves out some of the newer drugs. But it might be helpful to help you remember some of the different drug classes and treatment strategies. So the B in balsa is for bromocriptine. So instead of replacing dopamine, you can give a dopamine receptor agonist, like bromocriptine. Now, bromocriptine is an ergot drug, which means it's a peripheral vasoconstrictor, and it's going to tend to raise the blood pressure. So more commonly, if we're going to use a dopamine agonist, we use non-ergot dopamine agonists, including things like pramipexole and ropinirole. We also use those drugs to treat restless leg syndrome. Then the first A in balsa is amantadine, which is a drug that used to be used as an antiviral to treat influenza, but most strains of influenza are resistant to amantadine these days. But amantadine helps to increase dopamine release, and it also helps to decrease dopamine reuptake, so the dopamine stays around longer. Then the L in balsa is for levodopa and carbidopa, which we already talked about. The S is for selegiline and other drugs that inhibit dopamine breakdown. So there are two enzymes that break down dopamine, monoamine oxidase and COMT. So monoamine oxidase, or MAO, is an enzyme that breaks down catecholamines, and there's a form of monoamine oxidase called MAOB that preferentially metabolizes dopamine rather than metabolizing norepinephrine and serotonin and other catecholamines. So we can use a selective MAOB inhibitor, such as selegiline or rasagiline, to inhibit MAOB and to keep dopamine around longer. Now, selegiline is particularly helpful in cases of MPTP exposure because of that synthetic meperidine synthesis, because selegiline blocks the conversion of MPTP to the toxic metabolite MPP. So selegiline is the preferred drug for MPTP exposure. Then the other enzyme that breaks down dopamine is called COMT, or catechol O-methyltransferase, which converts levodopa to 3-O-methyldopa. And the drugs that inhibit COMT are entacapone and tolcapone, which always reminds me of the notorious tax evader Al Capone. Anyway, tolcapone and entacapone helped keep levodopa around longer, kind of like carbidopa did. So it's becoming more and more common to use triple therapy of levodopa plus carbidopa plus entacapone. And then the last A in balsa stands for antimuscarinics, such as benztropine. So besides low dopamine levels, Parkinsonism can also be associated with increased levels of acetylcholine. So there are a handful of antimuscarinic drugs, such as benztropine, that we can use in Parkinson's patients that might help to treat some of the rigidity and the tremor, but these drugs don't do much for the bradykinesia. Now, you can also treat Parkinsonism non-pharmacologically by creating a lesion of the subthalamic nucleus. Remember, we said that the subthalamic nucleus is an inhibitor of movement. So if you lesion the subthalamic nucleus and you remove that inhibition, you can facilitate movement. Now, previously this was done by creating a surgical lesion of the subthalamic nucleus, but now they do what's called deep brain stimulation, where they put in an electrode to overstimulate the subthalamic nucleus, and that essentially exhausts the subthalamic nucleus and has the same effect as a surgical lesion, just not quite so permanent. Now let's talk about some disorders not of hypokinesia, but hyperkinesia, too much movement. So there's hemibolismus, which is a wild flailing motion of the arm or the leg, but just on one side. So hemi means half, so this is affecting one half of your body, one side of the body. And I always see the word ball and I think about somebody flinging a baseball around. So it's a big wild movement, not little fine movements like we see with athetosis. Hemibolismus is due to a lesion of the subthalamic nucleus. And again, what does the subthalamic nucleus do? It inhibits movement. So if you stroke out the subthalamic nucleus on the left, you're going to see hemibolismus in the right arm. Now, another movement disorder is called chorea, which is brief, purposeless, non-repetitive jerks of individual muscles. Kind of just little jerking movements. So the word chorea means dancing, like choreography. So these are vaguely dance-like movements, except they're not really repetitive or rhythmic. Then myoclonus is a brief, sudden muscle contraction. Sounds kind of like chorea, but these can be repetitive. And this is almost just like a brief muscle spasm. Just the muscle just contracts on its own. Athetosis is slow, writhing, snake-like or worm-like movements in the hands and the fingers. And then one other movement disorder I'll throw in here is akathisia, which is just an uncomfortable sensation of just needing to get up and move, kind of a compulsion to move. So chorea and hemibolismus and athetosis and myoclonus are all involuntary movements. But when you have akathisia, you're choosing to move because you feel like there's something compelling you to get up and move. Now we're going to see akathisia again in psychiatry because akathisia can be a side effect of certain antipsychotic drugs. And finally, let's discuss Huntington disease. Now the old school name for Huntington disease was Huntington's chorea. So if you can lock down that phrase in your mind, it's going to help you remember that the movement disorder in Huntington patients is chorea, those brief, purposeless, non-repetitive movements. So again, it's a disorder of excessive movement. Huntington disease is an autosomal dominant trinucleotide repeat disorder. Now the mnemonic for all the features of Huntington disease starts with the letter C. So it's a CAG trinucleotide repeat disorder in a gene that's found on chromosome 4. So the next C is chromosome cuatro. Cuatro is Spanish for 4. It also tends to present in midlife, around age 40. So the Spanish word for 40 is cuarenta, so that's another C. There's also C for chorea, and you can use C for cognitive decline because Huntington invariably causes dementia, as well as depression and psychosis. And then the final C is caudate atrophy because on the MRI of the brain, you're going to see atrophy of the caudate nucleus and the putamen, which are part of the basal ganglia. Remember, that was part of the neostriatum. So there's death of these neurons because of excessive excitation by glutamate, which acts on NMDA receptors. So just like deep brain stimulation acts like a lesion, excessive excitation of neurons can be neurotoxic. Huntington patients also tend to have increased dopamine in the brain, which explains a lot of the excessive movement. They have decreased GABA, which makes sense because GABA is inhibitory, so they're losing their inhibition. And then they have decreased acetylcholine as well. So how do we treat Huntington's disease? Well, the excess movement is kind of like the opposite of Parkinson's. So for Parkinson's, we want to increase dopamine. So with Huntington disease, we want to block dopamine. And there's a drug called tetrabenazine, which blocks dopamine release. We use that to treat the chorea. If you remember all those C's in chorea and you remember chromosome cuatro, you can link that to tetrabenazine because tetra is Greek for 4. And occasionally we use neuroleptics like olanzapine and haloperidol to treat Huntington disease because they also antagonize dopamine. And that can help treat both the chorea and the psychosis that's present. All right, that does it for the basal ganglia. Now let's move on to the end of the session quiz. First question, what are the cardinal features of Parkinson's disease? So you have hypokinesia or akinesia or bradykinesia. You have postural instability. You often have that resting tremor or pill rolling tremor. You have rigidity, like cogwheel rigidity, mask-like facies, and also that festinating gait. Next, a 28-year-old chemist presents with MPTP exposure. What neurotransmitter is depleted? Well, the neurotransmitter depleted is dopamine. Remember, MPTP is converted to MPP, and that destroys the dopaminergic neurons in the substantia nigra. Next, how do each of the following structures normally impact movement? So the globus pallidus interna inhibits movement. The subthalamic nucleus stimulates the globus pallidus interna, so it also inhibits movement. It stimulates an inhibitor of movement. And then the substantia nigra pars compacta stimulates the direct pathway, which inhibits an inhibitor of movement. And the result is that it facilitates movement. And the last question, what neurotransmitters are altered in Huntington disease? Well, in Huntington disease, we said you have decreased acetylcholine, decreased GABA, and increased dopamine. And then for our rapid fire facts, depigmentation of the substantia nigra is seen in Parkinson's disease. Chorea, dementia, and atrophy of the caudate and putamen are features of Huntington disease. And then eosinophilic inclusions in the cytoplasm of neurons are the Lewy bodies, which we see in Parkinson's disease and also in Lewy body dementia, which we're going to talk about in the neuro lecture on dementia. All right, that's it for the basal ganglia. I'll see you next time.